Hello, welcome to my channel. So today we're going to be talking about abortion or miscarriages as our early pregnancy complications. Then outline we're going to go through definition, classification, epidemiology, etiology, and types and management, as well as go through the termination of our pregnancy act. Then for defining an abortion. So an abortion is a termination of pregnancy prior to the age of viability. So age of viability differs depending on where you are. In short, so the age of viability may differ from 20 weeks, 24 weeks, and 28 weeks. So that's a definition. So this is just an abortion, just a termination of pregnancy prior to the age of viability. Then quote unquote age of viability differs either 20 weeks, 24 weeks, 28 weeks, depending on where you are. Okay, so the more appropriate word to use is a miscarriage, even when we are referring even when we are counseling a patient with an abortion, you actually have to use the word miscarriage because it's more of an appropriate term. Okay, then classification can classify abortions or miscarriages as either spontaneous and induced abortion. And then under induced, that's where we can further group them into medical or illegal induced abortion. Okay, then we all know that epidemiologically, abortions are the commonest gynecological and obstetric disorders and the commonest cause of the first and second trimester bleeding, and about 15% of clinically recognized pregnancies end in abortion. Then most abortions occur between 8 and 12 weeks, meaning the first trimester of pregnancy. Okay, so meaning everything that occurs after the age of viability can't be called an abortion. It is called an intrauterine fetal death because it has occurred after the age of viability. Okay, then under the causes, we can have implantation, where we have about 20% of miscarriages, or the trophoblast fails to implant adequately. So that's one of the causes, failed implantation. Then two, can have chromosomal abnormalities, can have blighted ovum, can have multiple pregnancies, can also have maternal causes such as systemic lupus erythematosus, sepsis, can have diabetes mellitus, thyroid disorders, maternal shock, hypoxia, smoking, uterine abnormalities, uterine fibroids, cervical incompetence, can have genital tract infection or psychological factors. But these usually are increasing in second trimester. Okay, then types of abortions. We said we have spontaneous and induced. Then induced we already classified as medical and illegal induced abortions. Then spontaneous, the types of spontaneous abortions, we can have threatened abortion, we can have an inevitable abortion, can have an incomplete abortion, can have a missed abortion, can have a septic abortion, can have a recurrent abortion. Those are some of the abortions. So let's start with a threatened abortion. So the bleeding in threatened abortion is usually non-severe. Then the cervical wall is found to be closed and no effect. Then the uterine cramping and pain occasionally occur in the lower abdomen. Then there is also a backache that the patient might present with. Then the membranes remain intact and no tissue is passed. Then the fetus is actually viable. Then treatment for a threatened abortion, you can have bed rest, avoid coitus, and of course observation. Then under the second one, which is a missed abortion, you can have as a term which is applied to the fetus which has died and is retained with its placenta in the uterus. And you can also, some of the things which I've noticed is that you find that you do a scan in someone who is 8 weeks pregnant, and they find that the fetal heart is not aid, meaning there is no fetal activity. Then they put IUFD. So remember, like I said, if there's not yet the age of viability and there is no fetal activities, it's not IUFD. It's a missed abortion because the fetus has died and is retained with its placenta in the uterus. So know the terminology, the correct terminologies to use. Then clinical features under the missed abortion can have pain and bleeding, which may cease, but the mother may experience a residue brown vaginal discharge as having an odor of decaying matter, and it can be offensive and distressing. Then all other physiological signs of pregnancy will regress. Then uterine enlargement will cease, and the pregnancy test will prove negative. Then treatment of a missed abortion is so there is a criteria for misoprostol admission. So here we're just going to mention so we give misoprostol and an MVA with antibiotics. Then after 6 to 8 weeks, the coagulation disorders may develop if the fetus has not been expelled. So that's why we actually give misoprostol, so that we expel the fetus before the coagulation disorders set in. So we talked over misoprostol administration. So I'm just going to put up a picture for the current misoprostol administration criteria. So you can just pause and go through, because it is per week, so that you know when to give misoprostol. So hope you have paused and have gone through the misoprostol administration criteria. Okay, so moving on to inevitable abortion, you can have when it is so inevitable abortion means when the pregnancy is impossible to continue. So that's why they call it inevitable abortion. So the pregnancy is not going to continue. And under clinical features, we can have profuse vaginal bleeding, abdominal pain, then the os may be open, the os is open, and membranes are present or absent, and the fetus may be viable. So those are some of the clinical features. In treatment is also MVA plus antibiotics. But remember, depending on the gestation age, so that's how you treat an inevitable abortion. Then we go to the complete abortion. So this is our fourth spontaneous abortion. So complete abortion, you can have this is a pregnancy or which has completely with is expulsion of the embryo, placenta, and its intact membranes. So that's a complete abortion. So there nothing has retained, nothing has remained. So that's a complete abortion. And a complete abortion is more likely to occur prior to the 80th week of pregnancy. And there is a relief from pain, and the bleeding usually stops after the complete abortion. Then treatment, just give antibiotics. Then incomplete abortion is when the products of conceptions are only partially evacuated during abortion, so the abortion is incomplete. Then this usually occurs in the second trimester, and patients complain of passing blood clots and abdominal pain. And mostly, if you were to do a scan, you might find that there will be retained products of conceptions. Then treatment is MVA and antibiotics. So those are some of the terminologies used. Then the next is a recurrent abortion, which is defined as 3 or more consecutive spontaneous abortions. Then types of recurrent abortions, we can have primary, where all under primary we say where all pregnancies have ended in loss. Then secondary, we say one pregnancy or more has proceeded to viability. So remember, age of viability, we said that it may be 20, more than 24 weeks, more than 28 weeks, depending on where you are. So under secondary, we say one pregnancy or more which has proceeded to viability, with all others ending in loss. That's secondary recurrent abortion. Then it occurs in about 1% of women of reproductive age, and it is of idiopathic, and idiopathic recurrent abortion are common in about 50%, in which no cause can be found. Then the known causes, we all mentioned the same causes we mentioned can cause recurrent abortion. So just the same causes we are from mentioning. Then under management in idiopathic recurrent abortion can just support. So support is necessary from the husband, family, and the obstetric staff. Then advice. So advice, we talk about lifestyle modification. So if the patient smokes, tell them to stop smoking. If they take alcohol, tell them to stop. Then if they usually exercise a lot, you can even tell them to decrease their physical activities to reduce on stress. Then you can also give them drugs. So you can give them progesterone and human chorionic gonadotrophin, which can start from the luteal phase and up to 12 weeks. Then you can also give them a low dose aspirin, start from the diagnosis of pregnancy and up to 37 weeks. So those are some of the things you can start from the diagnosis of the fetal activities and up to 38 weeks, such as the LM and WH. Then in the presence of a cause, treatment is usually directed to control the actual cause. So that are some of the things in short we actually talk about. Then we go to aseptic abortion. So aseptic abortion is an incomplete abortion which is complicated by infection of the uterine cavity, of the uterine contents. So this may be due to criminal interference, so such as the illegal abortion we talked of. Then this is one cause, or most common cause, or just any incomplete abortion which is complicated by an infection. Then under the history, you find that there will be features of incomplete abortion, where there will be severe vaginal bleeding with passage of products of conception with or without history of evacuation. Then there will be features of pelvic infections such as pyrexia, tachycardia, general malaise, low abdominal pain, pelvic tenderness, and purulent vaginal discharge. Then under the bacteria, so the commonest organisms can have gram-negative, such as E. coli, streptococcus, staphylococcus. Then anaerobes can have bacterioids, so rarely cryptosporidium and tetany, which is potentially lethal if not treated adequately. Then types of septic abortion can have a mild, where the infection is confined to the decidua, which is common about 80%. Then you can have a moderate one where the infection extends to the myometrium, which is about 15%. Then severe septic abortion, which is where the infection is extended to the pelvis, plus endotoxic shock, and also disseminated intravascular coagulopathy, which is the least, and it's about 5%. Then under management, of course, you can do investigation, your full blood count, your blood grouping, close match, cervical swabs. So remember, not vaginal, just do cervical swabs for couch and antibiotic sensitivity, coagulation profile, serum electrolytes, and blood culture. If pyrexia is more than 38.5, then antibiotics. So antibiotics, they differ depending on where you're practicing. So you can give you IV and any broad spectrum antibiotics plus metronidazole IV. And then you give your surgical evacuation of the uterus. So this is usually done by someone who is experienced. So it is usually done 12 hours after antibiotic therapy until a reasonable because until we want to wait until a reasonable tissue levels of antibiotics have been achieved. Then post-abortion management, which is of course our pack. We also have to do the pack. Then the complications of this same abortion, you can have hemorrhage, you can have complications related to cervical surgical evacuation, you can have uterine perforation, you can have cervical tears and excessive cervical dilatation, you can have excessive curettage, you can have RH immunization, maternal depression. So those are some of the things we usually have to talk about. So we are done with with aseptic abortion, but I would like just to go through the post-abortion management. So under the post-abortion management, we can get support from the husband, family, and obstetric staff. We can also give you anti-D to all RH negative non-immunized patients whose husbands are RH positive. Counseling and explanation. Then we can give contraception, where we tell the patient that they should start immediately after abortion. If the patient chooses to wait, before ovulation can occur, 14 days after abortion, and so the pregnancy can occur before the expected next period. So that's why we tell them to start abortion immediately after the abortion has occurred. Then it's best to wait for 3 months before trying again, and this time allow to regulate cycles and to know the last menstrual period, and to give folic acid. Or if the woman wants to wait even longer periods, it's fine, because they have to be ready for the next pregnancy. Others might even tell them, okay, it's fine, you can even just be pregnant even after a year. That's if they that's what they want, so that they allow the body to rest. Okay, then under the Termination of Pregnancy Act, so they are different, but these are some of the things I picked out. So you can terminate a pregnancy if the continuation of the pregnancy is going to involve: 1, risk to the life of the pregnant woman, or risk of injury to the physical or mental health of the pregnant woman, or risk of injury to the physical or mental health of any existing children of the pregnant woman, or if there is a substantial risk that if the child were born, it would suffer from physical or mental abnormalities as to be seriously handicapped. So those are some of the things we consider. And this is the end of the tutorial. Thank you for watching, and see you on the next tutorial.